So physiological changes, this is going to be a review of Module 2. We start off talking about the skin system. So some of the different things we see as we get older are going to be that lentinges, or those age spots, or those liver spots. Excuse me. These are darkened areas on the skin that has been exposed to the sun throughout the client's lifetime. The seborrheic keratoses, these are slightly raised wart-like macules with distinct edges. They can be light tan in color all the way to dark black, but these are pretty benign conditions. Usually we don't do anything with them unless they cause some cosmetic issues, and then clients can have them removed. We also have those skin tags, or the acrocordones, as we begin to get older. Because of decreased elasticity of the skin and thinning of that epidermal layer, several different things happen. We have wrinkles that develop. We also have sagging of the skin, and the client is at an increased risk for hypothermia. If a client has been exposed to harsh chemicals, sun exposure, or they have really dry skin throughout their lifetime, then some of these things can begin to appear much sooner in life. And that thinner skin also will put the older adult at an increased risk for those horrible skin tears. As we age, we begin to lose melanin in not only our hair, but also in our skin. So skin colors begin to fade, get lighter in color, or hair turns gray, and hair distribution patterns begin to change. On our body, the hair begins to thin on the head, under the arms, and in the pubic area. But in the eyebrows, the nose, and the ears, those hairs can become thicker and a lot more noticeable. And after menopause, women can begin to grow facial hair. Fingernails will grow more slowly and toenails get thicker. Clients are less tolerant to heat because of a decrease in sweat gland function, and we also develop dry skin because of that decreased sweat gland and sebaceous gland function. So to help combat this, we encourage our clients to decrease the number of baths they take a week. They don't need to bathe every day as long as they keep their face, their hands, their perineum clean on a daily basis. We encourage them, instead of using hot water, let's try and use some warm water instead, because hot water is very drying to the skin. Make sure they're using moisturizing soaps and lotions, and staying well hydrated. They have a good oral fluid intake. And when they dry the skin, they need to treat it gently. So dry it gently, treat the skin gently, period, because of the risk of skin damage. We also begin to see senile purpura, which is going to be those bruise-like markings on the skin. They just barely bump their arm and they have this huge purplish, reddish, brownish discoloration to the skin that looks like a bruise, and it takes forever for it to go away. They have decreased fluid at the cellular level, so they're at an increased risk for dehydration. And as that subcutaneous tissue begins to decrease, we start seeing some hollowing. So it looks like their eyes begin to bulge, or their clavicles become much more pronounced because there's not as much subcutaneous tissue there. Clients are going to be at an increased risk for skin cancers. So it's very important for us to monitor skin changes and changes in moles. And if we're suspecting a potential malignant melanoma, use the ABCDE mnemonic. Um, we also know because of the decreased amount of subcutaneous tissue in the older adult, this puts our older adults at an increased risk for pressure injuries over those bony prominences. They don't have as much padding there to protect them. Older adults are at an increased risk for inflammation and infection of the skin. So moving on to the musculoskeletal system, we have a decreased bone calcium levels that start at the age of 30 or 40 years of age, and this causes a loss of bone mass. So eventually we're going to start seeing a loss of height in our older adults, and we have increased or a decreased amount of fluid in between the vertebral discs. So this can lead to that hunched back formation or kyphosis. We see decreased blood supply to the muscles and decreased elasticity of the tissues, the cartilage, which results in less flexibility of the joints. We have decreased muscle tone and muscle mass that results in decreased strength. So we really need to encourage our clients to help keep those bones strong by taking in adequate amounts of vitamin A, C, and D, and participate in some of those weight-bearing exercises, such as standing or walking, because that helps increase the strength of the bone, and making sure that they have a good hormonal balance. Osteoporosis will occur from an excessive loss of calcium and insufficient replacement of calcium in the bones. So it causes the bones to become very porous and brittle and fragile and very susceptible to fractures. We see this most often in our menopausal women, especially those that are small-framed, Caucasian, or Asian ethnicities. We have degenerative joint diseases that we see in the older adult. Osteoarthritis, which is the most common form of arthritis, comes from overuse of different joints, especially like the knees or the hips. Rheumatoid arthritis is more of an autoimmune disease that affects not only the joints but also affects the body system-wide. Bursitis is inflammation of the bursa, and definitely more common in the older adult. And gouty arthritis is the deposition of those uric crystals in the joints and other tissues. All of these can make ambulation or mobility very painful. So then that just creates a vicious circle of increased risk of blood clots and pressure injuries, etc., pneumonia. So talking about the respiratory system, because of decreased elastic recoil, tissue elasticity in the alveoli, a decreased number of capillaries at the alveolar level and in the lower lung, all of these result in a decreased air exchange or gas exchange. Because of that decreased amount of body fluid, we have drier mucous membranes. We have a decreased number of cilia, those little hairs in the nose, and those, because there's a decreased amount, it doesn't trap as much debris and it doesn't remove it. You know, that's how we get the snot, the mucus coming from the nose, for example, is the cilia helps trap debris and then it brings it back up so we can blow it out. But if we can't do that, then it gets down into the lungs and increases the risk of infection, especially when you couple that with the fact that we have a decreased number of macrophages. So a decreased ability to fight infections. Because of our decreased muscle strength and endurance, we have a decreased ability to take deep breaths and cough forcefully. And we also have an increased calcification of the cartilage, so the rib cage becomes more rigid and it decreases our lung capacity. So in the older adult, we see a lot of our COPD, so that's the chronic obstructive pulmonary disease, such as emphysema and chronic bronchitis. With influenza, the older adult is going to be at an increased risk of complications and an even more increased risk if they have a history of respiratory disease and comorbidities to go along with it. So it's vital that we encourage our older adults to get their vaccines on an annual basis. They also need to get the pneumonia vaccine. Pneumonia is going to be one of the bigger causes of death. You know, they have a comorbidity such as heart disease, etc., and it's going to be the pneumonia that will take them out. So they need to get their vaccines for pneumonia. Do understand that the older adults may not have fever or the changes in the white blood cells because of age-related changes. When we're doing skin tests for TB, skin tests may not be as reliable in the older adult. And lung cancer. This occurs most often in clients over the age of 65, and it's one of the most deadly forms of cancer. However, in the older adult, symptoms of lung cancer, we know it can be asymptomatic for a long period of time, but when they do start having symptoms, it can resemble pneumonia, so it may go misdiagnosed for a period of time. With the cardiovascular system, it becomes less and less effective with age. So we have a decreased muscle tone of the heart muscle. This decreases the cardiac output. The heart muscle mass begins to increase, especially in the left ventricle, which also decreases cardiac output. And all of this decreased cardiac output increases the risk of heart failure and decreases our peripheral circulation. We do have a decreased elasticity of the heart muscle and blood vessels. We have a decreased pacemaker cell, and this increases the risk of cardiac arrhythmias in the older adult. So we have those conduction abnormalities. Our blood pressure does not change appropriately according to the situations that we're in as we get older because of a decreased baroreceptor sensitivity. The older adult has increased risk of coronary valve disease. We also see some valvular calcification that causes more heart murmurs. The older adult has increased atherosclerosis, and this causes hypertension in the older adult. It's very common. There's an increased risk of orthostatic hypotension, again, because we don't have that baroreceptor sensitivity functioning appropriately. So the older adult does not respond as well to postural changes. We see dependent edema and varicosities in the older adult because of the sclerotic vein changes and decreased heart function. We do know that coronary artery disease is going to be present in some degree in most people over the age of 70. A lot of the older adults might have seriously obstructed coronary arteries, but they're pretty asymptomatic, so they're not aware of it. So if they suffer a myocardial infarction or a heart attack, their mortality rate is going to be much higher, and they're more likely to die suddenly from a heart attack. Again, congestive heart failure is usually a problem of the older adult, but a lot of older adults see these symptoms of heart failure as normal signs of aging. So they don't think they need any help. They just think they're getting older until something serious happens or they get very sick. Even though cardiomegaly or heart enlargement is not routinely seen in the older adult, it is not uncommon. It is common to see peripheral vascular disease as we age and occlusive peripheral vascular problems such as blood clots in the immobile client. We see varicose veins in the older adults that are obese or inactive, or they spend a lot of time standing because they no longer have that vascular muscle tone. And aneurysm development is common in the older adult that has arteriosclerotic blood vessel changes, or a history of angina or MI or heart failure. With the hemopoietic and lymphatic system, again, as our body fluid volume decreases, we have increased plasma viscosity. So our blood gets thicker as we get older. We also have decreased red blood cell production, decreased mobilization of the neutrophils. Remember, that's part of the white blood cells. We have an increased immature T cell response, even though the amount of T cells doesn't decrease. So this increases the risk of the older adult to develop infections, including those hospital-acquired infections. These clients have a decreased immunity to diseases such as tetanus or diphtheria, and their infection symptoms might be more difficult to recognize. For example, there's an absence of fever and chills with pneumonia, or they have a lack of dysuria with UTIs, or an absence of pain with peritonitis or appendicitis. With anemia, remember this is an inadequate level of red blood cells or hemoglobin. The most common anemias that we see in the older adult is going to be the iron deficiency anemia, the pernicious anemia, which is the lack of absorption of vitamin B12, and folic acid deficiency anemia. In the gastrointestinal system, we have increased amount of cavities in the teeth or tooth loss. So this can decrease the ability to chew and take in adequate nutrition. These clients have decreased thirst perception, so this also increases dehydration and, in addition, constipation. There's a decreased gag reflex, which increases the risk of choking and aspiration, and a decreased muscle tone at the sphincters, which increases heartburn. Excuse me. Decreased saliva and gastric secretions will slow down digestion, and it also interferes with our ability to absorb nutrients and absorb medications. Because of a decreased gastric motility and peristalsis, we have more flatulence, so more gas, more constipation, and more bowel impaction. The liver size begins to decrease and the enzyme production decreases. So now we have a decreased ability to metabolize medications, so it increases our risk for toxicity. Some of the disorders we see include the hiatal hernia, which is a protrusion of the stomach into the thoracic cavity or the chest. And that risk will increase with obesity and as we get older, so over the age of 50. GERD or gastroesophageal reflux disease often will occur with hiatal hernias, and it also increases the risk for aspiration in the older adult. Gastritis and ulcers are inflammatory changes in the mucosa of the stomach and the duodenum. And the older adult with these issues don't have the classic pain, but rather they have more of a generalized pain. Their activity decreases along with their appetite, and they may experience weight loss. Diverticulosis and diverticulitis are going to be the small pouches in the intestinal mucosa, and those can become inflamed. And over half of Americans are going to have some diverticuli by the age of 60. Colorectal cancer risk will increase as we get older, so routine screening is recommended at least after the age of 50, although they're starting to lower that age. Hemorrhoids are going to be varicosities of the rectal or anal tissue, and we frequently see this with constipation or obesity. And rectal prolapse, or bulging of that rectum through the anus, is going to be more likely in women that are over the age of 60 and multiparous. In other words, they've had many pregnancies. With the urinary system, the kidney size will decrease and lose a third of its efficiency by the age of 70. We see a decreased number of functional nephrons, so we have decreased filtration and removal of drugs. So we're unable to eliminate a lot of those toxic chemicals. We have a decreased blood supply, which decreases the removal of body waste, and it also increases the concentration of the urine. Decreased muscle tone will increase residual urine volume. In other words, even after we've urinated, we're still retaining some urine because we just don't have that muscle tone to completely empty the bladder. We also see a decreased tissue elasticity, so it decreases bladder capacity. We have a delayed or decreased perception of a need to void, so this increases the incidence of incontinence. We have an increased nocturnal urine production, so ordinarily in the younger adult, we don't produce much urine at night, but as we get older, we start producing more urine at night, so we're having to get up and void. In the male, we have an increased size of the prostate. So this increases the risk of infection, hesitancy, and frequency of urination, but it decreases the strength of the stream of the urine. Urinary incontinence is not a normal occurrence with aging, although it's not uncommon with the older adult, male and female. Urinary tract infection increases with age, especially in women, because the urethra becomes even shorter, and of course with its close proximity to the anus. In chronic kidney disease, this is often a result of chronic health problems such as high blood pressure, diabetes, and chronic urinary tract infections. And with the nervous system, as we get older, as with most everything, the brain size and weight begins to decrease because of a decreased cerebral cortex volume. We have decreased cerebral blood flow, and it makes the older adult more vulnerable to depression. There's a decreased number of brain cells, and this slows thought processes and decreases the older adult's ability to do multiple things at once. So multitasking may become a thing of the past. Doesn't mean that the older adult is demented, doesn't mean that they're losing their ability to do anything, to think productively, to do things, etc. It usually just means that it takes them a little longer. There is a decreased number of nerve fibers, so we have decreased reflexes, coordination. We have decreased amount of neuroreceptors, so we're not able to perceive different stimuli as well as we once did. Decreased peripheral nerve function decreases our motor responses, and it also increases the risk for ischemic paresthesias in the extremities. Some of the disorders we see: Parkinson's disease. This is a progressive degenerative disease of the central nervous system, with symptoms usually beginning after age 40. And there is an increased incidence in the older adult. A lot of people that do develop Parkinson's will also develop dementia. Dementia is a permanent and progressive mental disorder. It's characterized by personality changes, confusion, disorientation, deterioration of intellectual function, and impaired memory, judgment, and impulses. Alzheimer's dementia is going to be the most common form of dementia, and it's common in people over the age of 65. Doesn't mean that everyone over the age of 65 is going to come down with Alzheimer's, but we just see it more prevalently in that population. And it's more common in women because of increased longevity. Delirium. This has a sudden onset of confusion, and usually it's just temporary or transient. It may be caused by infection or trauma, different medications, surgery, etc. Transient ischemic attacks, or TIAs. These are brief episodes of cerebrovascular insufficiency, usually because of a clot or some type of obstruction. Usually it will only last a few minutes, but it can last up to 24 hours. And it may be the warning sign of an impending stroke. And a stroke is a cerebrovascular accident that causes a disturbance of the blood supply to the brain. It most commonly happens in people over the age of 65. Ischemic strokes occur because of a lack of blood and oxygen, usually from an embolus or a thrombus or, a blood clot. And the hemorrhagic stroke will occur when there's a weakened blood vessel or maybe an aneurysm that ruptures spontaneously. And often that can be because of hypertension. With our eyes, we have a decreased number of eyelashes and shorter eyelashes. This increases the risk for eye injury. We have decreased tear production, which increases the potential for eye irritation. We have an increased discoloration of the lens, which causes a decrease in our ability to perceive colors. Decreased tissue elasticity in the eye can cause blurring, and that decreased muscle tone decreases the diameter of the pupil, decreases our night vision and our peripheral vision, and increases those refractive errors, which means our ability to focus and sensitivity to glare. Our eyelids become less elastic and they begin to sag. The older adult may develop a grayish haze of the peripheral cornea. This is called arcus senilis. Blepharitis is a chronic inflammation of the eyelid. Diplopia is double vision. Some of our older adults will develop cataracts, which causes a clouding or a haziness of the lens in the eye. Glaucoma is a disease where we see increased interocular pressure in the eye, and that can cause damage to the retina. And age-related macular degeneration will occur most often in people that are over the age of 50. It is more common in the Caucasian population. The client's vision becomes decreased with the dry form of macular degeneration, but it can become lost with the wet form. And retinal detachment. This is the separation of the retina from the choroid. Excuse me. With the ears, as we get older, the tympanic membrane begins to get thinner. And we have decreased tissue elasticity, which causes a decreased ability to distinguish high-frequency sounds. So older adults often hear the lower pitched sounds better. Decreased joint mobility, we have those bones in the middle ear. That decreased mobility can decrease our hearing ability. We have a decrease in the ceremonous cells, those cells that create the earwax. So this increases the risk of impaction of the cerumen and causes conductive hearing loss. Atrophy of the vestibular structures and those structures in the inner ear can cause increased balance problems. Presbycusis. This is the term that is used for hearing loss that's associated as we get older. Otosclerosis is a hardening of the stapes. That's the little stirrup-shaped bone in the middle ear. And that can interfere with sound wave transmission into the inner ear. Tinnitus is the ringing in the ears, and this is a common report by older adults. Deafness is that inability to hear sounds fully. And 3 different types of deafness that we talk about, or hearing loss in this course, is conductive hearing loss. This is due to interference with sound wave transmission. Sensorineural hearing loss is because of the receptors in the inner ear or the cranial nerves have been damaged or destroyed. And central deafness is caused by trauma or disease in the brain's temporal lobes. Another issue with the ears is Meniere's disease, which is a chronic disorder of the inner ear. This affects our balance and it causes ringing of the ears, that tinnitus, and hearing loss. Issues with taste and smell. We have a decreased number of papilla on the tongue, so this decreases our ability to taste things. You have to have a stronger taste for them to be able to get that flavor that they once did. And they have a decreased number of nasal sensory receptors, so this decreases our ability to smell. Moving on to the endocrine system. We have decreased pituitary secretions, mainly the growth hormone, so we have decreased muscle mass. We have decreased production of the thyroid stimulating hormone, so we have decreased metabolic rate. We have decreased insulin production or increased insulin resistance, so this increases our risk for diabetes type 2. There's a decreased production of the parathyroid hormone, which increases the amount of calcium that's in our bloodstream. Estrogen and progesterone production will drop significantly in women after menopause. So this is what causes the development of that facial hair. It also causes the genitals to atrophy. In men, testosterone will begin to decrease gradually. With diabetes mellitus type 1, this is not tied to aging, but type 2 becomes more likely as we get older. Hypoglycemia is a complication of taking insulin or those oral hypoglycemic agents. And hypothyroidism is reduced function of the thyroid. It is more common in the older adult than it is in the younger adult. We need to be cautious though, because treatment of hypothyroidism can actually reduce bone density in the older woman, and they're at increased risk anyway. With our genitourinary and reproductive systems. With women, once again, we have decreased estrogen levels, and this leads to decreased vaginal secretions. We have decreased tissue elasticity. This causes decreased pubic hair, breast tissue mass, the decreased uterus size, vaginal size, and an increased fragility of vaginal tissues and tissue irritation and pain with intercourse. There is an increased vaginal alkalinity, so now we have an increased risk for vaginal infections. Uterine prolapse. This is where the uterus prolapses or falls into the vagina. This is a common issue with older women. Vaginal infection, once again, can be due to that change in the alkalinity of vaginal secretions. And breast cancer risk increases as we get older. In men, we have a change in the size and the firmness of the testicles, and the scrotum becomes enlarged. They have that gradual decrease in the testosterone levels, so this can decrease the amount of facial and pubic hair. And decreased circulation can decrease the rate and force of ejaculation and decrease speed in gaining an erection. And prostate gland enlargement is very common in the aging man. Prostate cancer is a major cause of death in the older adult man. With elimination, the human body needs to be able to get rid of waste products to be able to function properly. This is accomplished through the urinary system and the gastrointestinal system. And every person's elimination pattern is going to be different, but as long as it's effective, we don't need to be intervening. Different things that will affect our elimination patterns will include our diet, our fluid intake, our activity, and our lifestyle. Excuse me. With bowel elimination, the typical adult bowel movement will consist of a moderate amount of formed brown stool, and we pass it without difficulty. Although the frequency of stool elimination might be several a day, most adults will experience bowel elimination every 1 to 2 days. The urge to defecate will most commonly occur about 30 to 45 minutes after a meal because it's going to stimulate, or peristalsis will stimulate those nerves. A common defecation time is first thing in the morning following a warm beverage. The typical adult will experience the urge to void when the bladder holds about 300 mLs of urine. Most adults are going to void about 6 to 10 times a day. However, illness, medication, changes in the daily routine, all of these can interrupt normal elimination patterns. Many older adults have problems with elimination, and some of those common problems include constipation or diarrhea or incontinence of the bowel or bladder. Remember, constipation, we have that hard, dry stool that's difficult to pass, and frequency is not really a good measure of constipation. Excuse me. It can be caused by inactivity, decreased abdominal muscle tone, immobility or having to wait for help to get to the bathroom, not taking in enough fluids or not having enough bulk in their diet. Some diseases can increase this risk, as can some medications. Unfortunately, a lot of our older adults may become dependent on laxatives or enemas in order to move their bowels. If they repeatedly ignore the urge to defecate, this can lead to losing that reflex to be able to evacuate the bowel. Sometimes a lack of privacy or embarrassment or fear of pain can also lead to avoiding or delaying defecation. So if they avoid or delay, this can lead to those hard, dry stools that can lead to pain, which can lead to avoiding or delaying defecation and suppressing that urge. So as we get older, peristalsis is going to start slowing. And inadequate activity also decreases peristalsis. These adults might be at increased risk for fecal impaction, which is a presence of a hardened mass of feces trapped in the rectum, and it cannot be relieved by expelling it. Diarrhea, on the other hand, is that frequent passage of liquid, unformed stools caused by rapid passage through the large intestine. So they're not getting the absorption of the nutrients, or if they take oral medications, it may be going through too fast. Seeing rectal pain or skin irritation around the anus are very common, and excessive fluid loss is a concern with diarrhea. We see more fecal incontinence with diarrhea, or older adults that are unable to recognize and respond to those normal sensations, maybe because of mental impairment or mobility issues. This can be very psychologically upsetting and embarrassing. They don't want to go anywhere. And this can be with fecal incontinence or urinary incontinence. Urinary retention is the abnormal accumulation of urine in the bladder where the bladder is unable to completely empty. And it can result from a variety of things. It may just be something as simple as that decreased muscle tone. But maybe they're not taking in enough fluid. Or if they're male, may have that prostate gland enlargement. And different medications, of course, along with anxiety, can cause urinary retention. With urinary incontinence, we have that involuntary loss of urine. It becomes a social problem. It becomes a hygiene problem. It is not normal in the older adult, however, it is common. It can cause skin irritation or skin breakdown, causes that isolation and psychological distress. The different types of incontinence, we've got the stress incontinence where the urine leaks when we have increased intra-abdominal pressure such as exercise or lifting heavy objects, laughing, coughing, sneezing. Urge incontinence, you have the urge to go and you just cannot get to the bathroom fast enough. Excuse me. The overflow incontinence, where we're leaking small amounts of urine because the bladder is too full. Functional incontinence is seen in the older adult. They have normal function, but they just don't have the ability cognitively or physically to get to the bathroom in time to take care of the issue. So always assess their elimination and fluid intake patterns. Explain different measures that can help improve the tone of the sphincter muscles, such as the Kegel exercises. Have them wear clothing that is easy to remove for toileting. Reduce environmental barriers by putting grab bars in the bathroom or toilet risers. Maybe we need to keep a urinal or a bedpan readily available. Making sure we respond quickly to call lights. Develop a toileting schedule. Familiarize the older adult. Where are the bathrooms in the facility? Make sure that we're maintaining skin integrity and, if necessary, provide incontinence pads or garments for these older adults.